chairpersons, panel of experts, and moderators, and the dear audience. Before going to start my talk, may I ask you a question? How many of you know about the hybrid planning? That's great. That's great. So I'm going to add a little more about the hybrid breast cancer planning. So before going to in details, I would like to key focus on the basic of hybrid planning, and then I'll show the comparison of 3D-CRT, VMAT, and the hybrid planning. And after that, I will discuss about the little benefits, clinical benefits, dosimetry consideration, and the outcomes, and then I'll summarize my talk. This is the quick facts of breast cancer. This is the global data 2022, and this report has been published in the last year, 2024, April. And if you see the incidence and the mortality rates of the female cancer, almost half of the contribution from our region, and also both are same in both incidence and the mortality. On the other hand, if we compare the cases, what we can see there, almost 1/4 of the breast cancer and contributing here. And the table, you can see that the female breast cancer rank is 2, and the mortality is, ranking is 4. At our hospital last year, almost 820 patients received radiation therapy, including different modality like 2D, 3D-CRT, IMRT, and BMAT. And we have been treated 392 right breast cancer and left breast cancer 428. Our attention today is the left breast cancer. So we all are concerned about the LABC, that this is the standard treatment approach with mastectomy followed by chemotherapy and the radiotherapy. So there's interesting data that has been published in the Lancet journal. The advantages of post-mastectomy radiation therapy, the reduces the chest wall recurrence by 3 to 4 times, and the overall survival is 6%. So if it is our choice of radiation therapy, then we can easily mention that the available technique like 3D-CRT, IMRT, and the BMAT are commonly used. And because 3D-CRT is the reference technique and is the widely available and cost-effective, definitely. Also, there are some few challenges like the low conformity and the homogeneity, under coverage, especially in the supraclavicular and the chest wall junction overall, and then the hydrogen spillage outside the PTV. On the other hand, if we talk about the IMRT and the BMAT, that help to reduce dose to the heart and the ipsilateral lung, improving the PTV coverage as well as the conformity and the homogeneity, and definitely the advantage of faster treatment time. So however, when we are talking about the BMAT in breast cancer, we have to take into account the healthy low dose radiation to the healthy tissue that already mentioned our previous speakers. And that causes the secondary risk of cancer. So why we reconsider our traditional BMAT technique? A lot of data set recently published in a few years about the low dose exposure to the healthy tissues. One of them is Byron et al. They discuss about the low dose path, especially the contralateral breast, lung, and the heart that exceed comparing with the 3D-CRT. And then in Ma et al. They also discuss about the mean heart dose and low dose volume to the lung compared to the 3D-CRT, possibly higher use of the IMRT over BMAT. However, the another report, a very interesting report that is published in the BJR journal in 2019, that they calculate the excess absolute risk developing a secondary cancer and observe the mean low doses to 3 gray and 5 gray. So this is just an example of the low dose radiation during breast cancer or VMAT radiation therapy. So if we can see the low dose radiation, almost half of the lung, ipsilateral lung is exposed. However, also the radiation goes to the opposite breast, and also the heart. So it could be our solution. So we can talk about the solution of the hybrid VMAT. And so to improve the outcomes, we implemented it. Hybrid is a technique that combination of both, either it could be a VMAT or IMRT integration with the 3D field and fill technique, and that definitely aiming to cover the radiation to the chest wall and reduce the unnecessary radiation to the healthy tissues. Some of the background of the hybrid VMAT. This is the first one. This report published in the Nature journal. They compared the several data set among the hybrid and the 3D CRT, and they also compared the planning technique also. And the medical dosimetry, they also published the same. The interesting, the right-hand side, this data, they also talk about the different dose weighting of the hybrid PMAT and the 3D CRT. Some of the background also. So in our consideration, we key focuses on, we took the 10 breast cancer patient, and definitely chest wall, that include chest wall and the supraclav. The fraction size is same for all the cases, and we delineate the both lungs, heart, and the contralateral breast. Our planning consideration, for each patient, we created 6 dosimetrics that include the 3D CRT and VMAT. Then we compare with the different dose weighting of VMAT and the 3D CRT. That is 80% VMAT, sorry, 80% 3D CRT, 20% VMAT, and then 70-30, 60-40, and 50% 3D CRT and 50% VMAT. So for treatment planning, we keep the isocenter position in the chest wall and the supraclavicular junction. We keep the same isocenter for VMAT, 3D CRT, and the hybrid planning, same collimator angle, as well as the gantry angle is selected based on the curvature of the PTV. This is the simple table, how we perform our plan and what are the consideration that we make our plan. This is just an example of the hybrid planning, that combination of the 3D CRT and the VMAT. So our planning objectives, we consider PTV D95% should be greater than 95% of the coverage, and D2 we try to keep less than 110%, homogeneity nearly 0, and our objective to the conformity index is greater than 0.8. Heart, we consider the V20 less than 5%, and mean dose less than 4 gray. And for the ipsilateral lung, V20, V10, 5 gray, and the mean dose. On that, similarly for contralateral lung and contralateral waist, we consider the mean dose. And most of the data has been taken from the RTOZ 1005, and this is just the step of the treatment. So if we go to the result, we compare the 3D CRT. This is the comparison of 3D CRT and the VMAT planning. What we can see from the bar diagram, the 95% coverage is higher in the VMAT technique compared to the 3D CRT, and the maximum dose, that D2% is lower in VMAT comparing to the 3D CRT. Homogeneity, if you see the data, in homogeneity, the homogeneity is higher in 3D CRT comparing to the VMAT, and conformity is better in the VMAT technique. On the other hand, if you go to the mean heart dose, that is 3.5. This is much lower than the VMAT technique, and V20 lower in VMAT. On the other hand, for lung ipsilateral, if you go to the lung, you can see that. So if you go to the lung, V20 and V10, then the V20 is higher in 3D CRT but lower in VMAT. But when we're talking about the low dose of V10 and V10, that is much, V5 that is much higher in the BMAT technique. That is our concern. Why we're choosing the hybrid BMAT? Even the mean dose is also higher in BMAT planning. So this is the comparison of 3D CRT and BMAT planning. So this is the 95% isolose line. This one is the 95% isolose line. Then we took the 50% isolose line, and then the low volume, that is 5 gray, we considered for 3D CRT. And on the other hand, we can see the BMAT, this is the low dose radiation, this 5 gray, that is very, very much higher comparing to the 3D CRT. So a different proportion of the hybrid BMAT. So if we see the D95 and D2% is, there is not that much significant difference, but the higher in 70% and the 80%. But if we talk, when we go to the 60% and 40%, there is a difference between the these two hybrid plans. So in our study, we suggested if anyone want to choose which they will select for their hybrid planning, they can go for the 80% and 20%, 80-20 or 70-30, any of them. So this is just an example. Again, this is the comparison of the 4 dose weighting, 80-20. If you see the low dose radiation 5 gray is much lower. When we are going to the 70-30, it's a bit higher than the 80-20. But when we're talking to the 60-40 and 50-50, especially in the 50-50, is much higher than the other 3 dose weighting. So these are the just few other works. They have also done this study of the dose weighting and the hybrid planning. And this is just an example. This data has been published recent year, and also the in 2020 to 2024, many research has been published. So almost all the technique based on the 3D CRT and the PMAT, and they suggested data that it is clearly mentioned that when we are talking about the hybrid planning, we can improve the homogeneity, we can improve the conformity, and also some of the cases definitely of the low dose radiation is our main concern. So the question may arise, so when we are talking about the hybrid planning, so do we need the skin flash? So open fields typically contribute the 70 to 80% of the total weight, and that include flash, compensate for the patient positioning, breathing motion, and the setup errors. So if we take this percentage, 70 to 80%, 3D CRT and 20 to 30% BMAT, maybe we can ignore the skin flash, but if the ratio is less than that, then we have to consider the skin flash. So then I'm not going to details of the skin flash. So this is my key summary. So at 70 to 80% dose weighting from 3D CRT and 20 to 30% from BMAT was found to be optimal for hybrid technique. If we talk about the hybrid planning is the preferred approach for the target volume, definitely 3D CRT for the wear sparing, lung, contralateral lung, ipsilateral lung, and there's an extremely significant difference highlighting the quality of the 3D CRT and VMAT. So we realized that those to the contralateral based lungs are indeed low in our hybrid, that is less than 3 gray. So as I mentioned earlier, so it is important to mention that the increase of low dose bath will provide in principle an increase in secondary cancer risk at different year post mastectomy. So thank you very much for your attention.